Good afternoon, everyone. So today we are going to have our eighth session on pain and its impact. So I'm very happy to introduce you all our faculty, Dr. Aju Mathew. So Dr. Aju is a medical oncologist and currently working with Ernakulam Medical College and Kolancheri Medical College. And he is also the director of Kerala Cancer Care Cochin, faculty of University of Kentucky Marke Cancer Center USA and Manipal University. So he's been a good friend of Pallium India and also a consultant too. So, sir, once again, welcome to this session. And before that, I have to inform the agenda also. We'll be having a session for 40 to 45 minutes from the faculty side. And after that, we'll be having a discussion on the same. And then by 4, we'll be starting our case presentation. And after that, we'll be having again a discussion on the case presentation. So that's the agenda. So once again, welcome and please, sir.
Thank you. Please interrupt me if my connection is poor, then I'll have to connect it to the Ethernet. Can you hear me well for now?
Yes, sir. Yes, sir.
Okay.
Perfect.
So it's very good to see everybody very keen to learn palliative care and what it entails. This is, I think, the fourth session that I'm taking on the same topic, which is talking about pain and its impact. I'm a medical oncologist. I've been taking care of patients with cancer since 2012. And since then, I have had a very close relationship with the field of palliative care, as well as experience in taking care of patients with pain. So let me share my screen and take you through the presentation. Please interrupt me if you have any questions at any point of time. Okay, so the discussion today is about pain and its impact. And if you ask even a little boy or little girl, or an elderly man or a woman, any age, what is the impact of pain? The answer is it is bad. In whatever language you say, the answer would be it is bad. So I don't think I need to explain what the impact of pain is on a person's life. I also don't think I need to explain further about the impact of pain on the caregiver's life. It is bad. How is it bad? It affects one's physical well being, it affects one's emotional well being, it affects one's social well being. So, in all aspects, pain can be disfiguring, can be disconcerting, and is excruciatingly troublesome for a person's holistic well being. Now, what is pain? I have heard about this definition several times, but let me repeat it again. Pain is a sensory experience associated with tissue damage. The experience varies from person to person and from time to time. Now, here's where I would like to make a small suggestion and a comment. Pain is not just a sensory experience, pain is also an emotional experience. So, it's not just what you feel in your body, but it is what you feel in your mind as well. It's also an emotional experience. And one person's pain need not be the same as another person's pain. One person's pain threshold need not be same as the other patient's pain threshold. So one of the most important lessons that I'm taught, that I teach when I take care of patients with pain is always believe the patient. The patient says they are in pain. So if the patient says they are in pain, my responsibility as a caregiver is to believe them. Pain is what the patient says it is. If the patient says, I have so and so pain, so and so intensity pain, believe it. And remember, pain, there is no definite test to gauge someone's pain. And because of that, it's called a subjective vital sign. what a patient experiences, what a patient describes is what their pain is. But here's where the point I need to re-emphasize comes. Different people may have different threshold for pain. So they may also not only have different threshold for pain, but they may also show the pain in different ways. The manifestation of the pain may be in different ways. Some may cry, some may just withdraw and be quiet, some may be angry. So people experience pain differently. There's no test I suggested, right? There's no test to find if a person is in pain. And as a result, one of the most common ways drug abusers abuse narcotic prescriptions in the West is when they go to a casualty or an emergency room saying they have toothache. If somebody says they have a toothache, there really is no way to figure out if they are if it is true or not. It's a subjective experience. But for palliative care, we must know that pain is what the patient says it is. Do not compare one person's pain to another person's pain. Now, the caregiver's challenge is to assess all the relevant factors without imposing any personal biases. For instance, I may be having a high threshold for pain, but my my patient, may have a low threshold for pain. So if they start crying for a small needle prick, I shouldn't tease them about it. I should accept that they have a low pain threshold. So at the same time, on the corollary, if a person's pain threshold is high, but your pain threshold is low, if they are not crying, if they are not saying, complaining of pain, it's okay. Take it easy yourself as a caregiver. A person's self-report of pain is the single most reliable indicator of pain. So if someone says they are in pain, accept it. But pain can be modulated, or the intensity of the pain can be modulated by various psychological factors: emotions, emotional well-being, cognition, their understanding, their intellect, a person's personality, individual response to pain. Some people have different coping techniques for pain. Some people have a various way of responding to an illness. Pain is an interplay of all these several factors. So the pain levels or the pain phenomena can be modulated by various psychological factors. But there are some objective signs that I can evaluate as a doctor. And those are high heart rate or tachypnea. Patients may be breathing shallow, deep breaths, shallow, rapid breaths. They may be restless. Some may cry, some may moan, grimace. Some may show resistance to care. Some may just withdraw. Some in some persons their mind just goes wandering. Some refuse to eat. They don't feel the appetite. Some have trouble sleeping. So there is various ways in which patients uh, express pain, but there are some indicators that a certain person is in pain. For a doctor, they can evaluate by looking at some of these measures. When pain is not treated properly, that is, if the pain continues and the patient is continues to be in pain, then that results in poor appetite, weight loss, disturbed sleep. They would withdraw from social activities. They would feel sadness, anxiety, depression. Some may act out, some may be aggressive, some may actually remain bedbound. Their movements actually decrease significantly. So Dame Cicely Saunders, who's considered as the founder of palliative care medicine, or the field itself, like the god of palliative care medicine, always describes what we call total pain as a suffering that encompasses all of a person's physical, psychological, social, spiritual, and practical struggles. Even if a person is atheist, they may still have a spiritual struggle with pain. I have seen that personally in patients I've cared for. So, a total pain is when you address the suffering that encompasses uh, a person's physical pain, psychological pain, social, spiritual, and practical struggles. So, you address all of these struggles together. pain control when they otherwise would not be able. So the objective of treatment is not just to relieve pain, but it is to improve the quality of life. Dr. Rajagopal sir would always talk about a person who continues to be in pain, uh, but the moment the palliative care organization in Trivandrum addressed and reassured the man who was in unaddressed pain that his son will be educated, his pain immediately responded to the medicines that they prescribed. So that person's pain was not just because he was physically suffering, that person's pain was because he was psychologically struggling, that he was having anxious thoughts. So the moment that was addressed, his pain was brought under control. So if you just listen to a couple of things that I say today, this is one part, the concept of total pain. The other part is where I just mentioned how you should believe the pain when a person says they are in pain. Now, as a doctor, how do I take care of pain? I always try to categorize pain. I think of pain that can be treated and healed. I think of pain that can be treated and palliated. For example, a person has toothache. Sometimes, if you extract the tooth, that pain is completely resolved. That is a pain that can be treated and healed. Sometimes I have patients with cancer who have chronic pain. Their pain can be treated and palliated. It will not be gone, you can palliate. So, as a result, to diagnose somebody's pain via examination, via investigations is very important. So, whenever I discuss palliative care with my colleagues, with lay people, I always tell them palliative care is one where doctors, nurses, healthcare providers are as vital as caregivers. You cannot take one and do palliative care with just lay people, volunteers. You really need those people with skills to diagnose, because some of the pain may be diagnosed and and if treated can be cured, can be healed. So proper diagnosis via examination, via history taking, via investigations sometimes do help in taking care of somebody's pain. So we in Kerala always talk about getting somebody access to some of these care when they are in pain. So if a person is in pain, we see if they need further investigations, further discussion, further lab investigations, further examination to see if we can diagnose and treat. Example, surgery. Some surgical procedures can help, tooth extraction being one. Some procedures, if a person is having severe pain because of pancreatic mass pressing on the celiac plexus, sometimes giving a celiac plexus block will help the pain. Medications can sometimes help. Sometimes topical pain bombs can help. Sometimes parenteral medications can help. Sometimes we may need to use an integrative medicine strategy. You may have heard about using acupuncture to take care of pain. That is when you just don't focus on medicines alone, but also think about integrative medicine. Where I used to practice in the US, there was a practitioner who specialized in something called Jin Shin Jitsu. It's a Chinese way of tackling pain through meditative strategy. I used to have a colleague who specialized in Tai Chi. It's something similar to yoga that I believe the Chinese practice. I'm not sure where it originated, but using Tai Chi to take care of pain. Some focus on yoga. So integrative medicine is where you encompass the non-pharmacological modalities that are available that will help address some parts of the suffering that can come as a result of the total pain syndrome. And that is also vital. Sometimes care, like splinting and bracing for somebody with a leg pain, a fracture. Sometimes psychological care, counseling, therapy. The illustration that I just gave you about the man who was reassured that his child will be taken care of and educated if he passes away. That is a way of psychological care. But the most important measure to address pain, trust me, I reiterate this, I experience it, and that is to listen. So if somebody talks about pain, somebody says they are in pain, listen. Somebody seems uncomfortable, their mind is wandering, they seem restless, they're agitated, they're anxious, listen. That's the most important part. In terms of medications, The most important things we need to remember is don't wait for the pain to get worse. Treat pain early. So if patient is having continuous pain, then the medicines should also be given on a continuous basis. And always use the analgesic ladder to step up or bypass if the patient has significant pain. So you start with the easiest available medicines, and then you walk up the ladder and give weak opioids. And if the pain is still not controlled, give strong narcotic medicines. Some of the cancer patients may require a lot of all of this. So the way we talk about giving pain medicines is by the mouth, preferably, by the clock, on the time span based on the duration of action of a drug, by the ladder, that is, you can step up the ladder slowly, don't go directly to the third step. If they're having significant pain, it is okay to bypass. uh, Specialize for the individualized patient. You need to personalize the care, and you should give attention to detail to understand what part of the pain is unaddressed. I'll just describe a few patient scenarios that I've really experienced. I once saw a patient in my cancer clinic, and the patient, after I examined the patient and planned her treatment, said, "My maid is sitting outside. She has headache. A doctor saw her and ordered MRI scan of the brain. Would you help prescribe it for us?" I said, "Let me see the maid first." So now the patient steps back and her maid comes into the room. I talk to her, and without much delay, I could diagnose her pain with simple history taking. An examination helped too. What she had was sinus tenderness. She had sinusitis. She had this morning headaches, which gets worse if she puts her head down, which is you can palpate this part of the body and you can elicit of the skull and you can elicit the tenderness. So she didn't require uh, MRI scan of the brain. All she needed was a course of antibiotics and pain medicines for a course of 1 week, and she was fine. So diagnose pain. Not all pain doesn't have to be from a brain tumor. Uh, Listen to a patient, try to figure out what they are experiencing. Use the examination modality that is required. If necessary, use a investigative strategy like a scan or a blood test, but diagnose it properly. The second case is another person with breast cancer, but now the person has intense headache. Now, this person having intense headache that just got worse and some nausea associated with it. It was quite easy for me to figure out why she was having the pain. It was because the cancer had spread to the brain. So a scan of the brain was easy to diagnose that she had intense headache because of cancer that has spread to the brain. For her, my treatment of choice was steroids to reduce the intracranial pressure. There are patients that you would sometimes see, not necessarily with cancer, who may have intense headache. There are pain syndromes called cluster headache. All that you need is oxygen for a short period of time, and their pain gets better. Some patients have migraine syndrome. They may just need preventive medicines. A neurologist or a general physician can help with it. So not all pain needs to be addressed by palliative care physicians themselves, but please keep in mind that there are pain that can be diagnosed and cured. There are pain that can be treated and palliated. Case number 3 is a patient with stage 4 colon cancer with pain in the abdomen, in the right upper quadrant and left lower quadrant. A simple examination would have helped me understand, but all I needed to do really was to talk to her and figure out when she had her last bowel movement. She was significantly constipated. So constipation can cause visceral pain. And the answer to that pain is not to give more pain medicines, but the answer to that pain is to help relieve the constipation and produce a bowel movement. And that indeed helped relieve her pain. Case number 4 is a patient who was in significant pain, who was on a lot of pain medicines, but the daughter came to see me and talked to me about a lot of the family dynamics. Some part of the family wanted all sorts of treatment given to the patient. Some part of the family wanted just palliative care. So there was a lot of back and forth. This is quite common in India where multiple people hold themselves responsible for a person's care. So this resulted in significant stress and anxiety for the patient and resulted in significant pain that persisted for the patient as well. So the solution for this person's pain, I fell back on the concept of total pain. For them, it required psychological care, counseling to bring the family together, to address the dynamics. And that helped ease the patient and get her a very good palliative care control, a palliative care towards the end of life. The fifth case I want to talk, this is the last, is a man with prostate cancer. This patient's prostate cancer is cured, but he cannot sleep comfortably due to pain in the feet. Now, this happens sometimes because of the treatment that we give. And this is a kind of pain, which is, we call it neuropathy. This cannot be cured, but this can be palliated. So the goal for him, because of the pain, he cannot sleep. So if he needs to sleep, we need to get his pain under control. So a small medicine given at bedtime helped him sleep well, because I did not give him a sleep aid. I gave him something that addresses neuropathy in the feet. So diagnose something properly and take care of that, and you may be able to address a person's pain to a large extent. But there are some barriers to taking care of a person's pain. Patient tolerance may be a barrier. Some patients may say, I don't want anything, I'll take care of it. I'll just stick with whatever I have, God has given me. I don't need any medicines. Some patients, caregivers may positively help, may negatively help. They may not narrate what is happening at their homes. They may not give an accurate reporting of what is happening with the patient. They may come to see you and just give you their understanding of what a person is experiencing. Sometimes caregivers refuse to give pain medicines to patients, thinking that that can cause addiction. This is something that we often see in palliative care clinic in cancer pain. When patients require morphine, the relatives, caregivers refuse to give it, thinking that they get addicted, whereas the patient is in significant pain. So sometimes counseling the caregiver helps address a person's pain. In some instances, financial resources may stand as a barrier to a person's pain control. Sometimes resistance from healthcare professionals, doctors like myself themselves, stand as a barrier to a person's pain control. Out of ignorance, sometimes I may not know how much medicine I can give, how often I need to give. I may not be aware. So my ignorance can impact my patient's pain control. Sometimes lack of incentive to take care of pain. As an oncologist, I may get more incentive when I actually see a person and treat that person with chemotherapy, but I may not get an incentive when I take care of a person's pain. So our incentives to taking care of palliation or to palliate a person may pose a barrier to how well we can take care of a person's pain. Here's where you can help. Listen to patients. Talk to patients, family members, caregivers. Understand the concept of total pain. Understand that it is not just physical, it is also psychological, it is also social. Sometimes it can be spiritual as well. I recently recall a patient's son who was estranged with the father, and the father had cancer. There was a lot of trouble between the son and the father. The son never refused to come see the father, especially since he's super sick with stage 4 cancer. But I had a private chat with the son, and I explained to the son that the father is in really great danger, and that it is up to him, the son, to go back to his father and talk to him and bring rapprochement, or else the guilt will be lifelong. So I encouraged him to patch all differences and go speak to the father. And the end result is the father died with peace of mind, experiencing the love and care of the son. And the son could see and take care of the father as he breathed his last breath in his own in the son's arms. Always talk about multidisciplinary care. Emphasize that. Sometimes you may just not need a doctor, a palliative care doctor. You may need a counselor. You may need a psychologist. Let's talk about multidisciplinary care. Ask questions. What is affecting you? For example, the illustration that I told you about. Only because the palliative care services was able to ask questions to that man could they figure out that the reason why that person's anxiety and pain was unrelieved was because he was worried about his son. So ask questions. And finally, don't underestimate pain at all. Now, I will end my talk here, and I will see you in the next session. if you have questions or comments. I may not have answers to your questions, but I would welcome your comments more importantly. Thank you.
Will you please explain the pain ladder once more,
Yes, sir. So let
please?
me take the slide and show it to you in just a second. I believe somebody else will be taking a lecture on that. If not, I'll just explain that. Um, the pain ladder, what is it? The World Health Organization came up with some ways to help a doctor or a nurse or a healthcare provider take care of a person's pain. They figured out that patients have pain that can be sometimes easily controlled. Patients have pain that sometimes cannot be easily controlled, and you cannot just wait and watch. That is also based on the concept of how often we need to give a medicine to a person if a person is in pain, especially in a pain like cancer pain, where the pain is continuous. So experts came together and brought out this a concept called the WHO, World Health Organization analgesic ladder, where if a person has pain and that person is coming to see me as a doctor, I should, as much as possible, try to start with non-opioid medicines like paracetamol, like non-steroidal anti-inflammatory drugs like ibuprofen, ketotifen, um, or Aleve, naproxen, celecoxib, those kind of medicines. So non-opioid medicines like paracetamol, diclofenac, non-steroidal anti-inflammatory drugs. I can consider adding adjuvant medicines like an antidepressant if I need to at this stage. Then, if the patient comes back to me after being on paracetamol round the clock and tells me that they still have moments of excruciating pain, then I could consider adding a weak opioid. Weak opioid, an example commonly used one is tramadol. So I could use a weak opioid, add it to the non-opioid medicines. So such a patient's prescription would be something like tab paracetamol 500 milligrams 222 plus tab duloxetine 20 milligrams bedtime plus tab tramadol 50 milligrams as needed for breakthrough pain. Tab tramadol 50 milligrams 3 times a day. So that would help with increasing the chance for better pain control. So I added a weak opioid. A week later, the patient comes to me and says, even then, they are having significant pain. At that juncture, I would stop the weak opioid and would switch to a strong opioid medicine like morphine, like uh, fentanyl patch, like oxycodone in the West. There are different kinds of opioids, narcotic medicines. So at that stage, I would start opioid medicines. I could still use the non-opioid, I could still use the adjuvant medicines, but my main arsenal, my main weapon in my arsenal is the strong opioid. If a person has continuous pain, then I must try to give the pain medicines by the clock. That is, morphine's mechanism of action usually lasts for 4 hours. So if I'm giving somebody morphine, I should give it every 4 hours. I should try to individualize the pain management. A person's pain control may not be the same as the other person. So if I'm giving regimen 1 or A for this person, I should try to give individualized regimen for the next person who sees me. And every time I see the patient, I should try to figure out whether their pain is addressed or whether they are having moments of excruciating pain. If so, is it because of some non-compliance with medicines? Is it something I need to increase the dose? And keep in mind, I must also talk about side effects of pain medicines like constipation and address that as well. So that is basically the WHO analgesic ladder. Easily summarized, it is a way to escalate pain medicines for a person who has increasing pain. Let me see if there are some questions in the chat box. Hello, doctor. Okay. Hello, doctor. Taking second opinion for cancer treatment or family having multiple opinions about the same. How will you address this? Okay. Taking second opinion. So if a person comes to me and says that I want a second opinion, it is my responsibility to help them with that. I always say this. If somebody says, if a doctor says they will not help with a second opinion, that is the reason why you should get a second opinion. Okay, I'll repeat that again. If a doctor tells you that they will not help you with getting a second opinion, that is a reason why you should go for a second opinion, because I would immediately lose trust in that doctor. So as a doctor, as a responsible physician, it is my responsibility to help a person get a good second opinion if they need it. I always tell my patients that they are happy to get a second opinion. And sometimes, or most often, I also give them the list of the doctors that I would like them to see for a second opinion, because they wouldn't know who to go for a second opinion. There may be multiple doctors in the same city having the same specialization as you are, but not all of them may not be good or solid in their practice. So if I'm a good doctor, I must also help them find a good doctor for second opinion. But I don't always recommend them doctor shopping, going for a third opinion, a fourth opinion, and that kind of things. Next question. What is your advice on genetic counseling for the patient and the family, as it can prevent pain in future, which can be due to relapse? Absolutely. If a person's cancer appears to be from a hereditary reason, nowadays we have ways to test that person's genetic mutation and figure out if they have a hereditary or an inherited cancer. If they do have an hereditary cancer or an inherited cancer, then there are ways I can help that family escape from another cancer. So definitely genetic counseling in the right setting is of vital importance in prevention. Now let me ask everybody a question. Feel free to answer. Have any one of you ever prescribed morphine or seen a patient who was taking morphine? If so, uh, what did you feel? Was their pain controlled? Did they feel better than they were when they were not taking morphine? Any one of you? Have you either prescribed morphine or seen anybody on morphine? Unmute and speak, okay?
Good afternoon, sir. This is Mohan Kumar. Yeah, I have seen a patient who came with a chest pain in a emergency department, and morphine was given. At least he relieved his pain. I saw a patient.
Very good. Where do you work, Mohan?
In a Vivekananda Memorial Hospital, Saragur in Mysore.
Mysore. Thank you. Thank you for saying that. In cardiac chest pain, cardiac onset chest pain, where patients have heart attack, one of the quickest ways to relieve pain is by giving morphine, morphine injection, and that will help relieve the pain. Obviously, you'll have to do the further investigations and figure out if they have heart attack and do the angiogram and the angioplasty if they necessarily need it. But it is vital. It is of vital importance to relieve their pain. So, one of the mnemonic that I was taught in medical school for patients with cardiac onset discomfort is MONA. MONA stands for morphine, oxygen, nitrates, and aspirin. So MONA, M-O-N-A. So morphine stands at the top. I always think about that because it could have been Oman too, right? Oxygen, morphine, aspirin, and nitrates. Why did it become MONA instead of Oman? Anyway, thank you, Mohan Kumar.
Thank you, sir.
Has anybody experienced an instance where, okay, Ramakrishna, you had something to say?
Yeah, Dr. Aju, this is Ramakrishna from Mysore. I'm a volunteer at Palliative Care Center in Mysore, run by Swami Vivekananda Youth Movement. We have been extensively using morphine, and we have seen wonderful results out of that. it definitely brings down the pain and allows the patient to communicate. This is what we have observed, and we have also observed that patient whose pain is well managed, he can go back to work and he can be socially useful. We have seen patients working after the administration of morphine for 3 to 4 months or 5 months, 6 months. A flower vendor, he was totally bedridden because of pain. When pain management started with this, morphine and other medicines, he went back to the market, started selling flowers again, and he had a wonderful life for the next 6 months. Of course, he exited from the world, but his quality of life was maintained because of morphine administration. This is our experience. Thank you.
Thank you, thank you, thank you. It is a vital medicine, but unfortunately, if I am to guess, 99% of doctors don't know how to prescribe morphine, or I'm saying or, okay, I'm not saying and. Either don't know how to prescribe morphine or have never prescribed morphine. We are trying to change that through our efforts in Palim India. Very few doctors know how to prescribe morphine or have already prescribed morphine ever in their career. The medical education system in India is also changed. So now palliative care is part of the medical curriculum. So we hope that in the coming years, more doctors will be educated about the benefits of morphine for patients with uncontrolled pain. Now, coming back to the concept of total pain, I want to ask you a question and also listen to you all. Have you, in your personal life or in your professional life or in your voluntary life, experienced any stories like the one that I told you about how a person's pain was really uncontrollable, but once the team in Palim India addressed his emotional need, that is his worry about his son getting educated, then immediately his pain got better and his quality of life improved. So not necessarily through a medicine, but through a non-pharmacological method. Have you haven't had any experience? I would like to listen. Okay, I don't think anybody has much experience in that, but keep that in mind. Uh, the concept of total pain. So not all pain requires pharmacological methods. Not all pain requires medicines. Some pain can be modulated by a person's emotions. Some pain can be modulated by the person's family situation, uh, by differences of opinions between caregivers. Some pain can be modulated by coping skills. There are ways one can help with coping skills. I'm not an expert in that, but I'm sure there will be psychologists in the group that can help us in future sessions. So there are different ways one can modulate the pain and help reduce the pain, help reduce the pain problem that a person is having. Let me see if I have addressed all the learning objectives of today's talk. Meanwhile, if you have questions or any comments to share, please feel free to share. Okay, define pain. We defined total pain. We talked about the pain indicators. We talked about the psychological component of pain. We talked about the importance of non-pharmacological pain techniques. Uh, Indicators of pain when somebody is not able to express themselves. We sometimes see patients who are mentally challenged, who may not be able to say they are in pain. So how can you figure out if they are comfortable or uncomfortable? It's quite easy sometimes it isn't. So heart rate, you remember my slide that talked about heart rate, about restlessness, about anger, about withdrawing. All of these can be indicators that somebody is in pain, especially if they are unable to express it verbally. Okay, I think I've addressed everything. Uh, Rajalakshmi or Gayatri, what is next up on the agenda?
So next we'll be having a case presentation. So shall we proceed with that? Yeah.
Yes, yes, yes.
So we have a volunteer and a participant, a very vibrant participant in FCPC, Mr. V.S. Ramakrishna Mudre. I welcome you, sir, and we are eagerly waiting for your presentation because it is a quite different scenario. So welcome, sir.
Thank you, Gayatri. My name is Ramakrishna Mudre. I come from banking background. I worked in a publicity bank for nearly 32 years, 33 years. And since 2012, I'm a volunteer at palliative care program, which is run by Swami Vivekananda Youth Movement. This particular presentation, I selected for one reason, just to emphasize that palliative care is not just for cancer patients. It is also meant for people who are at the incurable stage of disease or disorders which are of chronic in nature. And when the disorders are chronic in nature and it has got a long lifespan, and in that lifespan, what are the things that can happen for the family? Probably that I'll try to bring it out in my presentation today. Next slide, please. Okay, patient is a female patient of 31 years, diagnosed with cerebral palsy with severe mental retardation. She attends a special school in Mysore. And next slide, please. The history says that after 2 days of birth, infant suffered accidental fall from the hands of paramedical staff in the hospital. There was a wound on the sternum, led to virulent streptococcal infection, leading to asphyxia and cyanotic expel. And after 14 days of struggle, child survived after opening the wound and draining the pus. However, parents started looking at milestones that are getting delayed and regular crying spells during the nights. Then it was termed as abdominal epilepsy. It was a time was fixed for that. Every day after 11:30 or 12 o'clock, child would cry very, very vehemently. Child would cry and pass motion and then go to sleep. Often stiffening of body with crossed legs. After a detailed assessment, it was diagnosed cerebral palsy with severe mental retardation probably because of the streptococcal infection, and also the fall which happened, which has caused the central nervous system, midbrain has been damaged. And the prognosis was very, very serious, that it is going to be a fully dependent child for life with a social quotient of 25 to 35. And the language is going to be very difficult to learn. And child was totally dependent for the entire activities of life. It was very vulnerable, frequently hospitalized for medical attendance. And every stage was difficult. Oral hygiene maintaining was difficult. Dental extraction had to be done every now and then with general anesthesia. And because the child did not have the understanding of self, he did not know what is its nose, or where the hand is, where the leg is. And finally, the parents decided at the age of 11 years probably to conduct hysterectomy to avoid menstruation. It was a very, very difficult decision for the parents. And just to see that this child is going to be socially acceptable, and also to reduce discomfort for the child, parents decided for salivary glands ligation and redirecting salivary ducts, and this definitely helped them. Due to constant monitoring and adjustment medication, seizures also it came to control. Nearly for the last 10 years, they don't have any seizure episodes. And about 4 years back, epileptic drugs have been stopped. Unfortunately, last year, the child suffered a fall, resulting in femoral fracture. and it is fixed by surgery now. The child is limping back to taking some baby steps now. She is almost in the stage when she was trying to walk at the age of 3.5 years. Parents are reliving those days when they were trying to make the child walk again. And the same thing has repeated after nearly 27 years. Now, looking at the insight, diagnosis of, because child is severely mentally retarded, she is not aware of diagnosis, prognosis of palliative care. Fortunately, family consisting of father, mother, and brother, they are well aware of these things. Family overview, now presently father is 66, mother is 57, brother is 36, and the child is 31 years now. Looking at the disorder, now cerebral palsy is normally which occurs during pregnancy or after pregnancy or at the time of delivery because of some accident or infection or whatever it is. It is going to be a lifelong battle which can never be won. But a child with cerebral palsy will become an adult with cerebral palsy. That is what has happened now here. Fortunately, parents are well aware of these things, and they understand that their daughter will never be close to normalcy. They often get concerned, what after them? Because of this, the implications again, because this is the pain and its impact, there is a title that has been given. What happens to the parents and the family is the continuous toll on physical as well as emotional aspects and also financial aspects. Now, mother suffered a very high BP and fibromyalgia, and now she is slowly coming back to normal health since about 3-4 years with continuous counseling and focusing more on the child's welfare and trying to empower herself to be more physically fit. But one question always, hello, am I audible?
Yes, sir. Yes, please continue. Sir.
Oh, thank you. The one question always bothers the parents is that what happens after we die? Son is very, very cooperative. He's doing very well in his profession. Cares very well for his sister. Very deeply attached to his sister. Another concern which recently got added, that unfortunately son's marriage was short-lived and it was dissolved by judicial process. Now, looking at the echo map, father is very well connected to the daughter. Daughter, she has got limited understanding about the relations. Mother is well connected, brother is well connected, and she loves to go to school, though she is totally non-verbal, but still she loves to go to school, and neighbors are good. And extended family support is one way. It's because they don't often visit. She is not able to recognize them and transact them well with them. And with the socioeconomic review, parents and brothers are well connected socially, maintain their good relationship, internal and external, financially adequate and contented. Father was working in a public sector undertaking since retired, feels sad that he could not reach the possible higher positions due to the child's condition. But having understood the responsibilities, he does not have any regrets about it. He has done well. Mother was teaching in a school earlier, now gets engaged in religious activities like learning new things in Tamil. There are a lot of religious scripts available now. She's trying to learn all those things. They have worked to establish a school for spastic children in Mysore. Since 14 years, a school for spastic children is being run. Now nearly about 75 children are getting the services. Psychological overview, though being parents of special child for 30 years, new challenges keep surfacing at different phases of life, bringing the morale down. But fortunately, it is bringing the morale down is for a short phase. They come back again, focusing the child's welfare again. A concern always festers what after us. A new concern that has emerged is that searching for alliance for the son for the second marriage is becoming difficult due to a disabled child in the family. There is a sense of rejection in the family. Now, with the total pain, a child is non-verbal. Parents have to keenly watch for the pain indicators. Symptoms may go unnoticed, constant vigil is needed for safety, which takes a lot of physical and emotional toll. On the psychological, front, they know that it's a losing battle, which has to be fought. Feeling of rejection, feeling deprived of a normal life and happiness as enjoyed by the peer group. Big question is, what after us? And family has managed to keep afloat well socioeconomically. When I have used this word very deliberately, keeping afloat, it takes a lot of effort to keep afloat when you have a social problem because of a disabled child at home. Spiritually, it appears that parents are quite strong. Father has determined to do his best till he's alive. Mother is seeking solace in his religious discourses and prayers. With this, probably, the question that comes up for discussion is, how do we counsel young parents who have just come to understand that child is not going to be normal for lifetime? And how the palliative care team can work to improve the quality of life of disabled child and the family, and how the community can support the family to conserve the family's energy. Because energy is not an incessant thing, it is going to deplete often. As the child is growing, parents are aging. It's going to be difficult to maintain or conserve the energies of parents. And this is the vital issue in all disabled children families. And how the community can help and how the palliative care team can help. Probably this is what needs to be understood and discussed. Thank you.
Thank you, Ramakrishna sir. It was a very clear and detailed presentation. Now the floor is open for all the participants. Let's have a fruitful discussion on the discussion points. So kindly comment in the chat box, or else you can unmute yourself and speak.
Mr. Ramakrishnan sir, thank you. Thank you for that very clear presentation. I could really visualize at least part of what the family goes through and part of what you saw in the family, because your presentation was so clear and well described. It is immensely painful to see such a story play out in front of your eyes. I cannot even imagine the situation at home for this family, for this person, and everybody who really loved this person. So I'm first of all coming to the front of the group and saying that as an oncologist, I have zero experience in addressing any of the questions that are being raised here. And I am very clueless, and that it is distressing that, that a lot of us will feel helpless. But I would really love to hear others' thoughts. For the last question that you raised, how can the community support the family to conserve its energy? Now, I have seen in the West, there are ways in which the government themselves or the county in a city provides allowances for the family to hire a person so that they can get a day off once every week or once every month. I have also seen instances where there are homes in which a person can be taken to, so that for that period of time, for example, for 1 day or 2 days, when the care is shifted to some other responsible party, the family can relax a little bit. I have never seen anything similar in India. And over here in India, all I've seen is 24/7 caregiving by the same family, to the extent that they get drained and emotionally down, and they get their life gets lost along with the life of the person that they're caring for. I would stop here. I would love to listen to other people.
Hi, it's Ryan. Hello.
Yes, Ryan, please.
Hello, can you hear me?
Yeah, we can
Yeah.
hear you.
Hi, it's Ryan. Yeah, thank you for sharing such a challenging case. I mean, I don't have all the answers, but I'll just share something that I've seen in my close circle. I'm based in Mangalore, and one of my friends' parent has a disabled child, and she went through this question of what happens after us. So they've started a care home, especially for children with special needs. So I think if the palliative care team can identify such a similar place in their local area, where they're not, I've not come across many care homes that address the needs for special for children with special needs. If they can identify such places, that kind of gives parents that gives parents the hope that there is such a thing. It's difficult, like the obvious answer for that, or the obvious answer would be the brother takes on the responsibilities, but caring for a disabled child is quite a challenge in itself. So I think yeah, if the team can identify care homes that address these needs, that would be step one. I think that would at least give one level of comfort for the parents. Yeah, I mean, I can I can only tell from the experience I've had around myself. I've seen parents with cerebral palsy children, and some of my I've got a couple of neighbors who have disabled children, and yeah, it is a 24/7 non-stop commitment. So any person taking on that responsibility is a huge thing. So I feel the only solution is a team, and that would come from a a specialized care home. There are I know in Mangalore, somebody started with a special school in Mangalore, just for these kind of children. But yeah, if the palliative care team can identify similar places in the local areas, then that would take one of the biggest concerns for the parent.
Thank you, Raya. Yes, linking them to the care homes for children with special needs can be one good thing which we can do. That is absolutely right. Yes, Tanvi.
Yeah, so I would like to probably answer the first question. How do we counsel the young parents who just came to know that the child will not be normal for life? First of all, understanding what it's just like breaking the bad news, and now the parents know that the child will not have a normal life. And so first addressing what the concerns the parents have for the future and the immediate future, like the short-term concerns and the long-term concerns. And after addressing those concerns, also helping the parents to probably delegate the certain responsibility to each, like the mother would be taking care of the child for a couple of hours, and then the responsibility would be shared by the father or by the brother, and also with the community support if there is any of the joint family or friends or relatives, anybody. And at the same time also helping the parents understand the strengths which they have in themselves of raising a special child. So it's more of using the strength-based approach in also helping the parents to understand that yes, the future is not that easy on how they are looking up to. And also the same way the person prior to me gave that answer, that probably after they are not there in the world, so the person can be placed into some facility with the help of the community and also the extended family to provide that much support.
Yes, thank you, Tanvi.
Yeah.
Then, yes, Rekala ma'am says that since parents are getting old and son already had a failed marriage, they as a team should sit and discuss the possibility of keeping this child in a good setup where there are trained people to look after such persons and visit her quite often. Yeah, true. Miriam, do you have anything to add with this?
Sorry, that was actually an accident. I didn't mean to raise my hand. I was just reading the chat. But since I'm on, I'd just like to say that this is a very, we have seen similar situations where so many people in the rural areas have CP kids who are now adults, and they have really no resources to take care of patients. The father may have passed away, the mother's the only other person in the family. And we see these adult CP, cerebral palsy people just lying flat in the community with the government not really helping in any way. So I think these are things that we need to work towards advocacy so that there'd be some help from the government for these families. Because unlike the case that's presented here, what we see in the rural community is that there's just nothing, no resource at all. There's a case that we know of. The child doesn't even is an adult person, doesn't even have an Aadhaar card, does not have a disability card because he doesn't have an Aadhaar card. So they don't even get ration and things like that. So this is the situation in rural India. And I think we've got a long way to go just towards advocacy for people like this.
Thank you, Miriam. It was a very valuable point that we lack a lot of government support in here also. We lack that. So proper advocacy is very necessary for people like children with special needs. So pension schemes, a lot of government schemes are there, but still it is very difficult it is very difficult to reach out. So it's very important advocacy. Yes, I agree with that. Then Dr. Hema Biju, that a spastic parent group or friends can volunteer to care for the kid once or twice a week, maybe just an hour or two, giving the couple a much needed break and some together time. Absolutely right. Absolutely right, Dr. Hema. I agree with that. Any other comments? Mm. Yes, community also plays a very key role here that the joint effort along with family to share the responsibility. So community can also play a major role where the volunteers play a very vital role. So this can be done, of course. Yes, Mohan Kumar sir has opined that that the parents were engaged such activities. Is there any chance to get involved volunteers to take care of the child? Yeah. Yes, Mohan Kumar sir, is there any attempt made to put the child school? Sir, can you answer that, Ramakrishna sir?
Yeah, child has been going to the school, and because of COVID situation now, the school is closed for more than 1.5 years now. This aspect also of disabled kids has not been addressed during COVID situation. This has to be, I think probably the community has to take it more seriously in work for the disabled community to see that the dignity of life is maintained. Nobody knows what is happening, whether all the people are getting this, vaccinations, or how the parents are managing the child. Nobody knows about that. But the child is going to school, definitely.
Sir, actually, I have a doubt. How do we counsel the young parents? It's absolutely a right question, because how it will be quite difficult to handle the parents, to counsel the young parents actually. So, what did you do there to make them to get along with the situation? What did you do actually?
Yeah. So here actually there is one very, very basic understanding. It applies to all parents, whether some parents are special child or a normal child. A child is a consequence of parental decision, and whatever the child undergoes, whether pleasant or unpleasant, parents are responsible to see that the child is protected, whether disabled or normal. If disabled, they need to empower themselves to see that they are kept quite fit as long as possible, because it requires a lot of financial support, a lot of physical support, a lot of social support, and a lot of emotional support. If three things can be kept intact, like the emotional fitness, your financial fitness, and physical fitness, a child can be taken care very well. If there is anything missing in these three things, life is going to be miserable for the parents as well as the child. Now, what happens normally for all the parents, young parents, they start experimenting with other fields of medicine, that thing, this thing. Somebody says, you go to Jaipur and Maulvi ke saath baat karna, wahan pe kuch ho jayega. You go to this Siddha medicine, homeopathy, that thing, this thing, everything they try. But what we have understood is, once the brain is damaged, normally it is irreversible. All the money that flows out is going to be waste. Instead, parents can store that money for the later life of the child when they are not there. Along with that, they need to see that they are available to the child whenever the child needs. They need to keep themselves physically fit. It becomes pertinent to see that they do their exercises, keep their muscles intact, and try to be young as long as possible. And finances are to be they need to be very, very judiciously, they need to spend, because the child needs that money. And probably the maintaining of the relationship with the extended family is extremely important for when they are not there. That's one thing, the next line of this, relationship people, they can take care of the child. And they need to be open with friends and relatives, not to get stigmatized because of having a disabled child. They need to keep talking to the people about the problems, what they're facing, not crying always. About the situation, they need to explain what is happening. And they need to engage with people often rather than getting isolated from the society. But when we focus on the welfare of the child, it will be definitely affecting the parent to realize that this is the thing what I need to do for my child. जब तक जिंदा हूं चिंता की कोई बात नहीं है, साला मैं मरने के बाद चिंता करने के लिए मैं है नहीं. As long as I am alive, let me take care of the child. As long as I am, let me be fit for the child. It is always a gray area what happens next. But instead of getting bothered about that too much and getting bogged down with those thoughts too much, let us look at the present, probably next 5 years, next 10 years. Let us reach the stage and find out, assess things and take appropriate steps at the time. And let us keep our finances intact. But unfortunately, most of the people who are having disabled children, they are not very rich. Very, very few kids are very, very lucky in this aspect. I have seen one single parent having 3 disabled children. How does she manage? unless others share their fitness, unless the neighbors share their physical fitness, neighbors share their social fitness. What we see in palliative care in all the 5 components, these are all the fitnesses. If any one of them or a couple of them are missing, it's going to be extremely difficult to handle situation. The community has to work with them, offer services. I know it is going to be difficult to build rapport with the family. People may not be open to receive help, but you need to build the rapport, talk to them, try to befriend the child, because child is not going to be very comfortable with strangers. It's a time-taking process. But if you don't initiate, the family is going to suffer for a very, very long time. My fitness has value only when I share it. Otherwise, fitness has no value. With this concept, if we start working, I think that the very fact that Kerala is working on the neighborhood networking concept, that's a wonderful concept. If we are able to spread it across India, I think Sarve Bhavantu Sukhinah will not be a dream always. We can be somewhere close to that. Thank you.
Thank you, sir. It was very clear.
Thank you, Mudra sir. Sir, I have a question to Mudra sir. Like, I know him since so many years. This is a totally question of he all have an experience of facing the same situation. This is a personal question to him, like how he come over on such an situation, or maybe this is the story of himself. That I want to know.
Yeah, this I did not want to bring it open to the forum in any case. Thanks for encouraging me for that, Mohan. Yeah, the story what you have heard is about my daughter.
Yeah, sir. Because what I thought, whenever we have a discussion with Mudre sir, always he is inspiring person to all of us in our organization, because he is taking care of his kids. He himself is a god for her, I think. So we need some elaboration on this. Like you can, this elaboration will definitely help us to deal cases in future. Maybe if we came across such cases.
Probably in some other forum, Mr. Mohan, because it's a story of 31 years. With a lot of difficulty, I have concised that.
Yeah. Sure, sir. I experienced that, how you have given the story. Definitely it is a motivation for us. Thank you.
You are absolutely a great inspiration for many of us. Salute, sir. Salute. We really salute you.
Gayatri, I was trying to avoid this because sometimes we feel that we have done something extraordinary. Actually, we are not. The entire population has got nearly about 4 to 6% of disabled individuals and their parents. Many people should be working very well. They would have done a lot of good things, and probably for other children also. But stories, they do not come up. And it is very difficult to say, when I'm talking about social stigma, it is so difficult. They say, we decided to go for salivary gland ligation just to see that her discomfort is brought down, because 3 to 4 t-shirts every day it used to get wet because of saliva, and also to bring up some improvement in the social acceptability. These things cannot be taught or expected from any person who does not have resources at all. As one of the participants, she was expressing, it is so saddening to see that. I was very fortunate to work in a public sector organization, keep my family comfortable. But how many people they have this opportunity? This is the reason why I keep telling that if I'm fit today, it has no value if I don't share it. Otherwise, we will be in palliative care. There's no care. We will be receiving palliative care someday without even thinking of how to share my fitness. We start receiving service without being entitled for. All the fit people in the society, whether he is physically fit, socially fit, emotionally fit, or cognitively fit, or spiritually fit, unless he shares that, there is no point in being fit at all. Thank you.
Thank you, sir. Thank you so much for sharing your experience. So, how palliative care team can work to improve the quality of life of disabled child and the family? So, since palliative care is an interdisciplinary disciplinary team, a lot of things can be done for not only for disabled child, for the entire people who are in need of palliative care. So, therapy can play a very good role here. That the daily activities of the child can be improved through physiotherapy or occupational therapy and all. And in the case of pain, yes, of course, we can do a lot. As you all have seen, a lot of cases that we can do a lot of things to reduce the pain when taking the physical aspects. And for psychologically, yeah, it is more important than the physical aspects, because counseling and making the couple or making the caregiver to get along with the situation is quite a difficult task. So it will, what we normally see in Parim India is that it is a quite a long-term process where the people will get along with the condition. So give them enough time. An empathetic approach is very essential to deal with people like that. And yes, of course, community plays a very major role here. And also linking a proper advocacy and networking can also be helpful to enhance the quality of life of the child or the caregiver or the family. So this is about the case presentation, and if anyone have any other alternatives or suggestions, you can definitely comment. We have around 15 minutes more to discuss. So if you have anything else to add, please put in the chat box, or else you can unmute and talk. So Dr. Hema or James, or I know some of the physiotherapists and occupational therapists here. Any one of you can give any suggestions regarding that, regarding the therapist?
This is Dr. Hema
Yes,
speaking.
ma'am. Yes, yes.
Hi. Yes, it was a very nice presentation, and unfortunately, we, as a therapist, I work with a lot of such children and their parents, and yes, it is saddening, disheartening, but the hope with which the parents work with these children, and the way they love and support these children, and each and every improvement or any achievement that we see with the child, it kind of brightens your whole day. So the thing is, in the chat box, I saw one of the participants had written that euthanasia should be an option and stuff. So the thing is, we see such so many such children and their parents, and that cannot be an option for everybody, right? So yes, whatever, like Mr. Mudre suggested, that one step at a time, take it slow, go, keep your goals small, and slowly keep achieving each and every goal, and with an eye towards the long term plan. Yes, that's the way to go ahead. Thank you.
Thank you, Dr. Hema, for your valuable points. So if anybody have any more comments, please, or else we can wind up the session. Anything to add by the team?
Yeah, I just have one suggestion, or probably not a suggestion, but how the parents can also be supported is through probably community-based groups in terms of similar conditions of other parents who are struggling with the same issues. So sort of a group counseling can also help them build that strength to face what is coming in the near future, and also facing what they are facing in the present time. So that provides a lot of support and also strength to the parents, who they probably can rely on each other in building up the support system. So sort of a group counseling session and support groups.
Yeah, I agree with you, madam. It's wonderfully articulated. Because the time span being uncertain, what happens after 5 years, what happens after 10 years, it's not going to be very easy to estimate. You may be having a lot of plans, it may not materialize. Teach our child to teach, but she may not learn. But parents and the teachers, even in the school, they need to move on with the child with the acceptance that the process is more important than the result. Though there is a target to achieve, short-term target to achieve and the long target to achieve, it may not happen at all. Then you need to revise your target, bring down the level of expectation, and start reworking. There is no end to, there's no question of stopping the process as long as the child is alive, and as long as the child and parents are alive together. I know very, very well that this is a losing battle, but I need to find happiness in fighting this battle with the acceptance that this is going to be lost. But the success is that how affectionately and how energetically I do it when I am doing it. Probably that is the answerability or accountability or the responsibility what I have towards my child. This is applicable for normal child and even the subnormal child. I'm not making any differentiation. Only difference is that there is a lot of emotional and physical toll and financial toll when you are taking care of a special child. That's all.
Definitely, sir, I do agree to what you're saying, and going through that battle of probably, as you said, that any day this battle would be lost, but how you are coping up and facing it each day, that is that sign of strength, and also that acceptance. And acceptance doesn't come in one day. It might take years or probably months, and it depends upon individual to individual. So that's how that group counseling or that support groups would help parents who are sailing in the same boat, and they can also provide strength to each other during this journey. So that's what my point was.
Yes, but for this group, I request and also I insist, when you come across parents of such special children, you please focus on their physical abilities. I'm talking about the parental physical abilities. As long as they're able to maintain their muscles intact, they can take care of their children well. That energy has to be there, because let me put it in a different way. When my child was assessed as CP with severe mental retardation, I was at the age of say 36. I saw nearly a huge group of people in Mumbai, a huge group of individuals who were disabled. Then I decided that there has to be some way out for this. And I could see a parent carrying a 14-year-old child and climbing the steps. Then I told myself that now I am at the age of 37, whatever the energy I have, I should be able to maintain till my daughter is alive. Since then, it has become my religion to see that I do my physical exercise religiously and keep myself fit. And that has taken this, as a byproduct, I was able to do well in my office, in my family, and probably even after coming out from my office, I've been able to share my fitness with somebody else. That is how I got into palliative care. So this has to be emphasized upon for the parents. As long as they are fit enough, their child, dignity is protected. Thank you.
Can I, Srish Kalra here?
Haji sir, boliye.
Mundra ji, I must salute you first thing. Secondly, you are from the banking sector and you have become an institution in palliative care that gives confidence in person, non-medical person like me. I am a veterinarian. That we can also contribute. I have, there is the word nishabd. We are, when you are speechless, you can't, you by your silence, you express everything. This is what I am in situation now.
Thank you very much, sir.
So yes, I think there is no more comments from the participants. So indeed, it was a great learning experience, and thank you so much, Mudre sir. And also, I would like to thank Dr. Aju Mathew, who left a few minutes back since he had an appointment. So thank you so much, and we'll be sharing the link to give your feedback. So see you all on next Wednesday. Thank you so much.
Thank you, Gayatri. Thanks for the opportunity. Thank you very much.
Thank you.